Yep, okay, I'm just going live now, Chair.
Okay, let me know.
We're live.
Perfect. Thank you, Yasmin. That's great. Good. Well, welcome everybody to today's joint Kensington and Chelsea and Westminster Health and Wellbeing Board meeting. It's good to see you all. Unfortunately, we are still virtual, although I'm sure, hopefully, the next one will be in person, in fact. So I just want to point out that as the last meeting was held by Westminster, I propose that I lead the discussions for this joint meeting of the Health and Wellbeing Boards of Kensington, Chelsea and Westminster. And I ask the RBKC board, those that are here today, to approve this proposal, and I'll take silence as golden. Give it a second. Nope, perfect. And then over to you, Tim, if you want to ask the same.
And this is Tim Mitchell from Westminster. I ask the same question to the Westminster members, and I would take silence as assent if we pause. Thank you very much.
Excellent, thank you. You'll all have heard this before, but we still have to read it out. Just to explain that the High Court has ruled that formal council meetings, including full council committees, including the Health and Wellbeing Board, must take place at a single specified geographical location, and that all participants must be present in a designated meeting place with the meeting open to members of the public. However, and this applies for today, if no formal decisions are being made, the meeting can be virtual. As COVID restrictions remain in place, although it seems to be changing, and no formal decisions are being made at this meeting, the meeting is being held via Microsoft Teams with participants joining remotely. The event is also being streamed live on YouTube. Members of the public and media are welcome to remotely follow the meeting and listen to the discussions. Committee papers for this meeting are available on our website, so via the calendar invite. And due to the size of the Health and Wellbeing Board, and to ensure the virtual meeting can run as smoothly as possible, only official board members, those presenting papers, and anyone who has requested a speaking slot can participate in the meeting. Everyone else should be able to view the meeting via the public live streaming, and any questions from the public are submitted in advance to ensure public accountability. I'm sure we're all very keen to come to an end of this housekeeping rules, but if everyone could please keep their microphones muted unless they're invited to speak, and to improve bandwidth, videos should also be turned off as well, unless you're introducing yourselves. If at any point I lose internet connection, I'll be handing over to Councillor Mitchell to stand in as a substitute chair. And if any participants wish to speak during the meeting, they should use the chat function in the top right of their screen to ask to speak or to raise their hand to ask a question. And if that's all understood, I'll move on to item 2, which is membership. And I understand we have apologies from absence for Councillors Rendell and Barnes, from Bernie Flaherty, and also from Janet Cree. I believe I saw Andrew Steadman in the meeting today, so no apologies there. And also to note that Darren Tully has retired from the London Fire Brigade, and of course we wish him well. Moving on to item 3, declarations of interest. So to ask all board members and officers to declare any interest that they may have in the items to be discussed. And again, silence will be taken as acknowledgement and assent. Excellent. And then also to ask whether there's any other matters arising at the moment. Good. Okay. I now ask the Kensington, Chelsea and Westminster boards for confirmation that the draft minutes of the concurrent board meetings on the 25th of November 2021 are an accurate reflection of that meeting. Perfect. Okay, that's got us through the housekeeping. Excellent. So item 5, this is your autism strategy being presented by Rachel Dickinson, and just a special thank you from myself, and I'm sure from Councillor Mitchell, for all the work she has done in pulling this together and making it such a user-friendly strategy. So over to you, Rachel. Thank you. But you're on mute.
I knew that was going to happen. I knew that was going to happen. Thank you, Councillor Kamali. We've also got a gentleman with us called Michael Hagan. So, Mike, if you want to pop your camera on and show everybody. So, Mike's a member of our local account group, and he's going to help me present the autism strategy for you all today. Mike's been an amazing representative for the local account group and also for many of our disabled residents throughout the development of this strategy. And so it just seemed perfectly fitting that he would join us today to present the strategy. Mike, do you want to just come on and say a little bit about you and who you are?
I'm Mike Hagen. I'm the member of the legal account group. I also work alongside Rachel.
Fab. Amazing. Thanks, Mike. So me and Mike are going to do a bit of a double act today as we present the strategy for you. So I'm kind of going to do the boring bits and just get you through those bits quickly, and Mike's going to do the really interesting bits, and hopefully you'll get a feel for all the work we've done to bring the autism strategy for you today. So this strategy is the second part of our all-age strategy for around autism. The first one was created by our colleagues in Children's Services and really sets the kind of foundations to really change the lives of autistic people within our boroughs. However, it was noted that while there is a section in there for autistic adults, it didn't go into the level of detail that our autistic residents would have liked us to do so. So at that request, we pulled together, using the 7 pillars of the all-age strategy, we pulled together an adults-focused strategy. So this strategy has been designed with over 200 people across both boroughs. I'm personally very proud of that, and I'll let Mike talk a little bit more about why that's so important in just a second, once I've got through, as I say, the boring parts. We do know that autism is underreported, underrepresented, and under-discussed. And so this strategy tries to challenge that, tries to change how we treat autistic people, change the language, and set some really ambitious goals and ambitious kind of milestones over the course of the lifespan of the strategy to improve, as we see, and listening to our residents, improve their lives living in the borough. The strategy wouldn't have been possible without some of our fantastic colleagues, some of our fantastic partners, all listed within the strategy. Hopefully you'll see in there, there's loads of stories, loads of case studies, and loads of really heartfelt kind of, what's that I'm looking for, heartfelt summaries of some of the work that people do to support autistic people in the borough. Some of the statistics that really are striking and kind of are the driver behind this strategy are, there are 700,000 people on the autism spectrum in the UK. It's a huge number of people. I think it's about 1.1% of the population. So we are talking about a huge number of people. Translate roughly to about 4,500 across the borough. And very sadly, nationally, 79% of them report that they feel socially isolated. We also have a statistic that says only 21.7% of autistic adults are in paid employment. The absence of many statistics, and those that we do have being quite so negative, are the reason and the driver behind this strategy. So I mentioned before that this strategy has been co-designed, co-produced right from the start with our autistic residents and our partners in the voluntary organisations and in health. And Mike, do you want to talk to us a little bit about why that's so important?
It's very important to always put the people first and making sure that their voices are representative in a meaningful way, I think.
Yeah, so it's really important that we're listening to our residents, we're including what they say, and that what we do is representative of what they've put forward. Is that right, Mike?
Yeah.
Yeah? And how do you think we've done with the strategy, with the autism strategy? Do you think we did a good job?
The team has done a very good job. I can keep getting people's voices in this orchestra. It's very good.
Thank you. I'm glad to hear that. I was a bit worried what you might have said then, Mike. Talking about our autistic residents and their voices, If we move on to talk a little bit about the design of the document. So we had a specialist autism friendly designer and an accessible designer help to design this strategy with our residents. Mike, do you want to talk a little bit about that? A bit more about that?
Question.
Ask the question again. No problem. I was talking about the design of the strategy and how it looks and how important it is that we worked with our residents to design the strategy and how it looks as well. It's not just what it says, but it's also how it reads as well.
The autistic strategy was designed and put together with the what's the word? I can't think of the word.
You're doing really well, Mike.
With the forefront of looking their ideas and how they see the world.
Exactly. How they see the world. Brilliant. That was exactly right, Mike. How they see the world and how that the people who are autistic can actually take on that document. So you'll notice that this document isn't full of bright colours or people's faces. It's quite muted. It's quite all the colours in there have a purpose, and all the colours help to translate that message. You'll also see there's not too many pictures of people's faces because these all fit in with autism friendly design. So we've tried from the start all the way through to make sure that this strategy not only works to improve the lives of autistic residents, but actually is a document that can be used by autistic residents. So I mentioned before that we looked at the pillars from the all age strategy, and we essentially placed an adult's lens on them. So we tried to make sure that of those 7 pillars, every single one of them is focused at delivering outcomes. One of the big challenges from our autistic residents, and actually all the residents we work with, Mike being one of the biggest ones for this, is all about real outcomes. It's not just about talking. This strategy needs to make a difference, and that's what we've tried to do. We have set some ambitious targets. We have set some ambitious milestones in here, but we're really confident that with the support of the community, who I have to say we've had a huge amount of support from, businesses as well, particularly our theatres, our cultural venues, museums, they've really pulled together to say we want to do something differently. And we're confident that with that drive, we can achieve improved outcomes for autistic people and their families. The pillars relate to all aspects of living their life, living people's lives in the borough, both boroughs. So things like planning together. We want to work closer with our autistic residents. We want to open up channels of engagement to autistic people. Mike and I, funnily enough, are currently working on how we can expand our local account group membership to that as well. Mike's doing an amazing job working across both boroughs to recruit more members and then target that to autistic people. That's just one part of all the work that we're doing here. You can see within the strategy, there's lots and lots of examples of ways in which we believe as councils we can be more autism friendly. As I mentioned before, we've got some fantastic partners on board. The strategy talks through so many individual stories, so many stories of businesses, places like Planet Organic, who've really changed the way their recruitment works, having worked with us. People like Veolia, who've reviewed their own recruitment processes. It's already in its early stages starting to see changes. We're so excited to be working with Buckingham Palace, with the English National Opera. I could go on and on, but the partners are really clear within the strategy. And hopefully you can tell from Mike and I, it's something we're really excited about making happen. I think I've covered most of the boring bits. Mike, did you want to hand off about anything else in it?
what I would like to say that I forgot what I would like everyone I would like everyone on this call to court and jump on the bandwagon or jump on the bus so we can get this orchestrated strategy and make it live.
Amazing. He wants everyone to jump on the bus and make it live. I don't really know what else I can say on top of that, Mike. I think you've absolutely encapsulated everything that our autistic residents have articulated to us through the development of this strategy. We will be coming back to report regularly to the Health and Wellbeing Board on the developments that we've made through their strategy. And hopefully, as Mike says, if you'll all be on this journey with us. I think that's it from us. Councillor, thank you very much.
Well, thank you both, and thank you, Michael, so much for coming today. That's wonderful, and thank you for the time and effort put in for a strategy that I personally really enjoyed reading, and I'm looking forward to seeing how we get on with all of those things. Does anybody have any questions for Rachel or Michael? Olivia, go ahead.
It's just a comment to say thank you to Rachel. I know she's put huge amounts of work into this with the local account group and Michael and others, and it's so great to have Michael here to co-deliver the work that the group have done. It's really inspiring. I'm very, very encouraged from a Healthwatch perspective. It's excellent to hear the voice of people directly into the heart of decision making. Thank you, Rachel.
Thank you very much.
Thank you, Olivia. Councillor Butler-Thalasis, your hand's up second.
Hi, thanks very much. So I have to say I'm the mother of an autistic kid myself, and I very much welcome the strategy. However, I do think that while the strategy does a really, really excellent job of describing the problem, I think it doesn't do as good a job in terms of committing to particular solutions. So I think that the problems that we have in terms of, for example, diagnosis, remain, and they're very big problems, and I can't say that it's clear from the strategy how they're going to be overcome. And I think that that's true, of a lot of the pillars, like the issues that we have around mental health. I noticed that there's a commitment for £50,000. That's, a commitment, but I don't think that will be enough to solve the problem. So, I think a lot of the issues that are raised, and they're raised really well and really, really well described, but the solutions are going to be much harder and will need a lot of work between different agencies. And so, I think this strategy is very much at the beginning of the journey, and we have a lot of work ahead of us before the situation is what we would like it to be for children and adults with autism. Thanks.
Thank you. Yes, I would agree. We're obviously at the beginning of a journey. I think this puts us on a good first step. Annabelle, your hand's up next.
Thank you. Yes, and thank you also to Rachel and Michael. I just wanted to pick up on the point that actually I think the cover note referenced the all-age strategy, which came before this one and had a children's focus, and we've certainly been thinking about and working really hard to turn that into actions and deliverables through a subsequent action plan, but also we're working very closely with adults, colleagues, and a broader partnership through the Autism Partnership Board. So whilst this is a strategy, there's quite a lot of work going on in driving it forward to achieve some tangible impact across for children and adults. So I suppose it's an ask that when we come back and report to the board about progress, that we do that with an all age lens.
Absolutely.
Thank you.
Thank you, Annabelle. And then Luxan Atnasingham.
Oh, thank you. So I'm the DI from the MPS. So just a really quick query. So just with regards to autism, just like mental health, has a spectrum, and I think it's a very sort of common theme that we're starting to see with a lot of the adults and children that we're coming into contact with. Is there an assessment for, you know, this spectrum and sort of intervention phases when identifying? Because it's, you know, mental health, I think, you know, NHS statistics documents, everyone seems to have some form of mental health, and it really depends on which end of the spectrum it falls under. So it's just something, I suppose, just to bear in mind. But definitely, I think it's a very good project in sort of increasing autism awareness. Yeah.
Rachel, do you have any answer to that one?
Yeah, I do actually. Did you say you're from the Metropolitan Police? Did I hear? So the line was
Yes,
a bit...
that's right. Yes. Yeah. I'm the DI for public protection.
Amazing. We've had the absolute pleasure of working with you quite closely on this strategy and talking about some of the work that's been going on in Charing Cross Police Station and some of the work that they're looking to pilot around identifying traits of people who are detained who may show autistic characteristics. There's some amazing work going on there, and I'm desperately racking my brains to remember the lead's name for it, but he's the lead for the whole of the Met as well as locally. He's covering Kensington, Chelsea and Westminster, and the projects that he's driving forward, he leads for the Metropolitan Neurodiversity Program as well. Some of those, hopefully, as time goes on, we will be able to identify those key traits that can improve it for the people that you come into contact with. So yeah, definitely something to keep a watching brief on, and to continue working together on. Very happy to catch up with you outside of here, and talk a little bit about that as well, if that would be okay, Councillor.
Yep, that's fine. Thank you.
Brilliant.
Thank you. I'm not seeing any more hands, so all I'm really going to say is to say almost what I said at the start, just how brilliant it is that our residents have been so involved. I believe it was over 200 autistic residents took part in this. You know, it's amazing that our borough are able to work so closely with residents to produce a strategy. I agree. Obviously, we're at the beginning of this, as the other councillor mentioned, but you know, I look forward. You can only build once you've laid some foundations. So it's a really great start. Thank you to everyone that was involved. Councillor Mitchell, your lens has gone on. Are you wanting to say something?
No, I wanted to very much endorse what you said, and to echo what Navsika Butler-Thalas has said. This is very much the start of the journey, and we working with Mike and others, it will be really important to get feedback in the coming months and years to make sure that the strategy and the actions that flow from the strategy remain relevant.
Excellent. So all that's left for me to do is to say thank you, and we'll be moving on to item 6 now. Thank you, Michael, again. That was really great to have you here on the call today. Brilliant. Have a good afternoon, both. Thanks.
Bye-bye.
So item 6 is now the primary care update from Dr. Andrew Steeden and Dr. Mona Vaidya. And yes, they're going to present an update on GP performance. Thank you.
Okay, thanks very much for the invitation along this afternoon. I'm going to take it as read that most of you have had the chance to read the report, so we won't go over it in great detail. But probably there are two aspects to this report. One is the work that primary care has been doing around vaccinating and the resilience work. So if I start with the vaccinating report, and then Mona's going to give you some updates on what primary care has been doing to stay open. So you'll be aware that primary care has been working under lots of stress. In fact, we all have for the last 18 months, but this winter was particularly bad. And one of the things that primary care has been incredibly involved in is the delivery of the COVID vaccination campaign. And the latter part of last year was the booster campaign. And this was accelerated in December when we had the arrival of the Omicron variant. Initially, we were hoping to vaccinate the whole adult population by the end of January, and then that variant meant that we had the challenge was accelerated to us delivering the COVID vaccination to the adult population by the end of December. By the beginning of December, North West London had vaccinated over 4 million, or given 4 million vaccinations, which was the highest vaccine delivery of any sector in the UK. We had the surge target in December to deliver to the whole adult population. So we had a target of delivering 230,000 vaccines a week. We never quite achieved that, but we did move from an average of 65,000 vaccines a week up to 180,000 vaccines over North West London. These were delivered most primarily through primary care, but with the support of community pharmacists as well. In the 5-week period in December, West London and Central delivered over 83,000 vaccines, and we went from being a couple of boroughs that were causing some concern with vaccine uptake to 2 of the best performing boroughs with regard to the booster campaign over the winter period. North West London is still delivering 5,000 first vaccines a week, which is really encouraging because these are people that are still coming forward for their vaccine to take up the evergreen offer to get their vaccine. We have particular plans around delivering vaccine to groups where there's been less uptake. So that's particularly younger adults, children and pregnant women, and very particular hyperacute communities as well. And the PCNs are preparing to start to deliver vaccine to 5 to 11-year-olds who are clinically extremely vulnerable. And that work will be starting on Monday. So that's an update on vaccine. I'll hand over to Mona now.
Thank you. Thanks, Andrew. So my bit is really talking about something that everybody's heard about, which is the Winter Access Fund. And I know that it's been something that was sort of, there was a mention in newspapers about £250 million of money coming to the NHS. So just to be clear, £1 million of that came to Westminster and about 900,000 came to West London. The winter access monies, the objective of it was really to increase capacity and improve access, and that was from between November to March. There were some temporary changes to GP or primary care enhanced services and QOF, which are basically like targets that are put in primary care in terms of monitoring long-term conditions. And the reason those were suspended was to allow work to happen around the vaccination program. But you know, as you can see in the paper, it was very clear there were certain things that were exempt from it, like the diabetes and mental health, so serious mental illness. And there was very much a clear instruction that we need to continue to focus on the vulnerable groups. So monitoring did not stop for those patients that required it, neither did access. And I think I just want to make sure that point comes through really clearly. It was really just to be able to reduce the routine work so that we could focus on those patients that were in need. Now, along with the winter, along with these things, there were some really exciting new developments, and the winter access money just helped to sort of be a catalyst to bring this forward. So one of those was hub working. You've all heard about hub working, but we sort of made our hubs into sort of little super hubs. So our hubs were providing even more access by creating little mini hubs in the deprived PCNs. And these mini hubs were providing like an overflow service nearly for the practices in that area so that the A&E admissions would be reduced. And obviously it was better for these patients to be seeing their GP practices. Apart from that, the hubs also increased the capacity for 111 referrals. And the hubs also provided the remote monitoring. And as you know, Omicron brought it with it, you know, we were getting hundreds and hundreds per practice. There were hundreds of positive cases per week. And one of the things that came out of that was primary care had to sort of go through these lists of patients and identify those that were high risk, and then refer them for remote monitoring or for monoclonal antibody treatment, which was a new way to deal with sort of the high risk individuals. And again, these hubs really helped to support that process. And obviously the hubs were staffed by our own local GPs. And another thing the hubs did was really to retain the talent. So like, we are really employing people locally who know the local areas. And I think that is something that will help to ensure that some of the good work that we've done in these hubs doesn't just end at the end of the winter access monies coming to an end in March, but it continues into the future. So these were some of the things that happened. Apart from that, you know, we did some work around care homes as well. So there was the adoption of the frailty nurse that came that really helped to support increased access. We also had community champions. So the community champions was a really interesting role because they focus on the high intensity users and really signposting them and utilizing the social prescribers more. Along with this, we also did telephony was one of the things that was an issue. Like we'd heard from patients as well as from practices that it was difficult for patients to get through to their practices. And so cloud-based telephony is coming into play. It hasn't yet taken off, but it's very well in the process. And I can't forget mentioning the Afghan Evacuees Program, because as all of this was happening, we were still working with the local authority to deliver on the Afghan Evacuees Program, and it supported 700 people, and it was a dedicated primary care resource where these evacuees were actually based, and it helped identify local, you know, obviously long-term conditions within this population, identify safeguarding issues, and also help them register so that they could have ongoing care and continuity. So these were just some of the highlights, and I'll stop there. Thank you.
Thank you. And yes, very interesting report. I mean, what a phenomenally busy you've all been anyway, but this winter was even more just incredible to see. I was watching all the queues. Anyway, I shouldn't be talking, I should be taking questions, sorry. So we've had one from Tanya in the chat box, but Tanya, do you want to speak, or is the chat box enough?
No, I'm happy to defer to the chat box. Thank you.
Okay, so for people watching on YouTube, the chat is moving forward, timing to recommence the availability of business as usual, face-to-face appointments, routine testing, etc. Who would like that one?
Do you want me to answer? Yeah. So I would say to Tanya that actually none of that was closed. And I think I need to reinforce that point, that there has been instruction from NHS England today that says GP practices need to go back to focusing on routine care. But I think I can speak for Central and West that as PCNs, none of our practices were closed, they were open, we were delivering face-to-face appointments, and we were offering routine testing where it was required and needed. And I think the lines between what we were doing and what we should be doing are so blurred because, to be fair, like we all just pick up the work wherever we have time to do it. We just continue doing it. I don't think anybody turns around and says, well, today I was told to stop doing routine work and tomorrow I need to just start again. It is very much just getting on with the day-to-day. And I guess the bit I would say is that we're firefighting less. So it gives us a bit more time to look at all our patients that, you know, who are the routine sort of reviews, medication reviews and things like that. I hope that helps in explaining.
I mean,
Actually, if I can just say, I fully appreciate how busy the GP practices have been, without question. But I'm not sure I fully agree that it was always face-to-face appointments were available and access. And perhaps it isn't just routine testing I'm talking about, it's all the normal screening processes, which you will be aware of have been set back because of obviously COVID. So it's more the issue that residents continue to report to Health Watch. When will they be able to have a routine access to their GPs? And if they, the patients, choose to have the face-to-face appointments, that they can have it rather than just having a phone triage. Thank you.
Thank you, Tanya. And Andrew, I think you had your hand up next. Perhaps you.
Yeah, so just to say, I mean, we're very aware that there are some areas that we haven't been able to do, and Neville Purcell, you remember Neville from before, has been leading some work on hypertension. So primary care is looking at a structured return to business as usual over the next few weeks and months. So they are aware of the scale of the issue and are making plans to get back to normal.
Thank you, Andrew. And then we've got Lena. Lena, your hand is up
Yes,
as well.
thank you. I agree with Tanya. The BME patients are continuously facing this difficulty getting a face-to-face appointment. As we know, patients, this majority of the BME patients do have language difficulties, and they just do not have the ability to convince the receptionists and the triage people in effectively communicating, expressing their problems. And it's not easy, even at the best of times, to express fully and clearly the problems. And these kind of access problems are further increasing inequalities in accessing GP services. And one more comment I have with this report is it possible at some point to have patient voices expressed or stated? Because the patient voice has to be at the heart of the primary care, and the updates are very informative and it's very helpful. But unless we know what patients are saying about these services, and especially when you're in the process of developing future proposals and systems, etc., wouldn't it be a good idea to get feedback from the patients at some point? And I know you've made reference to PPGs and Health Watch and so on, but at the moment we do not have a regular, adequate, appropriate forum to bring in the patient voices into this kind of board meeting.
Thank you. And Mona, your hand went up. I saw, so perhaps you're looking to answer.
Yeah, thank you. I think, thank you, Elena, for bringing that up. Your first part of the question, I actually forgot the second bit about the patients. I would say that we are working with Health Watch, and I know Olivia is on this, and we have been meeting with Olivia, and we are trying to create a structure which basically feeds this patient feedback into all the different levels. So I appreciate that it isn't ready yet, and then again, not to make excuses, but because primary care has been so focused on, we haven't really had a rest up from vaccinations and then getting back into sort of the routine swing of things, that a lot of the stuff hasn't, we stopped and started it, unfortunately, but we are back on it, and we've had recent meetings, and we're hoping to come back with something much more concrete. So I can just reassure you that that is going on and definitely happening. Olivia's got her hand up, so I'm going to just stop there.
Thank you, Lena. I appreciate the challenge. I think it's a challenge we keep need to be reminded of. We have a complex and nuanced communities in our boroughs. We need to keep our eyes and ears open, and indeed the PPGs and our local committee members provide that. We've completed our second round of small grant projects, which have included Filipino communities and a number of others, but absolutely, Lena, more channels, and the earlier the conversation, the better. And so, we'd like to, obviously continue with our capacity and your capacity to keep raising that voice and the challenges that our community members and residents experience. I would echo what you've said. Yeah, thank you, Lena.
Thank you all. And just for the benefit of those at home, Andrew's written in the chat box that there is also a structured North West London CCG engagement program, that is led by Rory, which is attempting to get ongoing patient and resident engagement in CCG policy, strategy, and co-design of services. So that obviously goes some way to answering the questions. Do we have any other hands up for this topic? Okay, so just to say thank you, and yes, it was incredible effort over the winter period, but obviously, as you've heard today, there's still some concerns out there in the community that we can look forward to hearing more about. Oh, Mona, there you go. Final word.
I just recognized that actually the first part of the question that Lena said about the face-to-face, I did want to say that we have been measuring, part of the winter access program was to review practices where there was face-to-face and telephone access. And so I hear that clearly there have been some patients reported, but just to put it to the committee here today, Central London and West London are really high in the percentages, and I think this is well over the national average of 50%, and we're closer to the 70% mark in terms of delivering face-to-face appointments. So I hear that clearly there have been some concerns from certain groups of the population, not some of the work that we need to be doing with Health Watch, but in general, we provide more face-to-face appointments in Northwest London CCG than the rest of London does.
Good to hear it. And thank you both for the paper today. If there's no further comments, then I'll move us on to item 7. Oh, Lena, sorry, you want the last word, and let's make this the last word on this topic, but you're on mute, Lena, sorry.
I'm sorry, I have to quickly respond to Vaidya here, Dr. Vaidya here, because it's a postcode kind of lottery when it comes to GP services and PCNs, where we are working Church Street area, which is the most deprived ward in the whole of Westminster. Things are not the same. So when you generalize your statistics and reports, it doesn't feature how desperately our patients are suffering when it comes to not having access to face-to-face appointments. We have more than 42 to about 50% of our residents in Church Street are of Muslim background, and they have difficulties with language. And so the situation is very different from, for example, Pimlico or Belgravia or south of the river. So you surely must make some allowances for these kind of areas.
Yeah, completely understand. And actually the Winter Access Fund, that's what I was referring to in terms of the deprived PCN area. I was referring to Regent's Canal, which is what the area you're describing. And there were 3 mini hubs that were created with the Winter Access monies to provide extra access. And this includes face-to-face access for patients in that area. And it's continued. I mean, that is still going on. And we're also working with the front door of A&E to be able to redirect the patients so that we can provide and we can actually see them face to face. But agree, Lena, that this needs to go alongside actually community champions and getting that message to the community that this service does exist and to utilize it. So that's the bit that we'll be working with Olivia.
Thank you.
Brilliant. Thank you, everyone, for that item. Yes, item 7. I'm introducing Rachel Sony. I believe this is your first Health and Wellbeing Board, perhaps. I think yes, you've recently joined the Borough, and yes, you'll be presenting an update on the Health and Wellbeing strategy and our yearly meeting schedule. So over to you there. Thank you.
Thank you, Chair. Yes, my first board, really pleased to be joining you at a time when we're looking to refresh our strategy and being part of driving the action forward for our residents. So thank you for that introduction. Introducing the report briefly to you, I'll take it mainly as read, but just to introduce it briefly to you and update the board on our approach to developing a refreshed strategy, a single strategy for Kensington, Chelsea and Westminster. With the 2 strategies that we have at the moment would roll forward, and then we would have for our joint Health and Wellbeing Board 1 strategy going forward for the next few years. So we've also included the way that we'll aiming to do that and the approach so that we can get your input to that. And we've got a suggested annual schedule of meetings with a forward plan so that we can really forward plan our agendas and the important topics that we want to discuss here. We can vary that as we go, depending on priorities and how we're achieving things. So that's included for you. And to remind board members of 2 really well facilitated sessions that we had with the LGA. We've had ongoing input from board members about the development of the strategy and how we can begin to consider evolving the board and looking at the membership and how we can really take a strategic viewpoint of the needs of our residents and how we're going to improve health and wellbeing and reduce inequalities for our residents over time. So that's really important. Quite a lot of changing landscape with the NHS and introduction of integrated care systems and place-based partnerships. So again, there's lots of context living with COVID about why we're refreshing a strategy. So we have, it is a good time for us to be refreshing our strategies with lots of changes and ways that we can work with our residents. So we've started to scope out the strategy, including the context of living with COVID. A big action focus is what we're wanting. The same with the comments around the autism strategy. How do we get action for our residents and real change over time so that we can really see that happening for people? And bringing back at least annual reports to you on how we're doing against that and having delivery plans that really focus on action. So I think it's important to note, set out in section 2.2 of the report, the reasons. We've set out some of the reasons why we want to do that and what a combined strategy might need to have, as well as a set of draft principles that we invite your comment on in 3.3. And particularly important, are we getting the engagement right with our communities, our individuals? Are we engaging with the right groups, and how are we building in what we've already learned and who we've already spoken to, etc. So we really do aim to have a read across from other boards into the Health and Wellbeing Board, making sure we're making best use of all of the different groups and delivery groups and transformation that's going on, so that this board can really take a good strategic position and consider its membership going forward in all of that context. Also, the report sets out that we really want to have a set of population and individual outcomes. So that's going to be really essential for the strategy so that we can really start to affect change and close the gap on some of the inequalities that we do have in our borough. And we talk about addressing diabetes. We've got over 15,000 people in Kensington and Chelsea with depression, and looking at diabetes and obesity as well is also really important. We're looking at maybe having some themes. We've got 5 ICP place-based priorities at the moment, so we've listed those out in 3.6. We could start with those and amend them as we go, depending on how we're achieving and what our priorities are and how we're doing. So that's what we're proposing in the paper. And of course, a vision and a statement is going to be critical once we've really developed through the strategy, how we set out what our statement is and our vision, and of course, welcome input from the board into how we really set that vision and statement out. We've got a timetable in 3.9 that sets out how we plan to develop the strategy to get it to kind of sign off and approval and launch in July. So it takes you through the steps of hopefully how we'll get there. Particularly important how we engage people along the way. We need to look for maximum engagement, particularly having a read across into other areas of engagement. So that's really essential. There's a meeting schedule in Appendix B. So we've started to look at really good forward planning. Again, invite comment on that, a mix of meetings and workshops of how the board can really work together quite closely. There's a focus in there, hopefully you'll see, on how we can engage and spend time with our residents, getting a flavour and their needs and wants into the strategy that we can then turn into action plans. So yeah, we'd like to seek your views on that. And then really it's about moving the board into really taking reports that relate specifically to delivering our strategy, really giving it that profile, making that really important, avoiding any duplication that we might have, and moving the board into that really good space. Thanks, Chair. That's all from me for intro. Any questions? Happy to take them.
Thank you. That was exactly it. Does anybody have any queries? If you'd want to put your hand up to ask Rachel. Ian. Thank you.
Hello, hi there. First of all, I'm really excited about the continued work that's going on in terms of reformulating the Health and Wellbeing Board. So really excited to continue to be involved in that. My question was more just around about the priorities and to an extent the proposed dates in the appendix at the end. So I think you're right, it doesn't tend to make sense that we align with ICP priorities. So that does make sense to me. But I do have a slight concern that when we're looking at a post-coronavirus, or hopefully a post-coronavirus, and the impact that that's had, I think it's generally accepted that children and young people, learning disabilities, and older people have been disproportionately affected. And of those three groups, we do have specific days for learning disabilities and children and young people. And I just wonder, I know there's one for dementia, and I wonder whether it might be possible maybe just to change that to older people. I appreciate very separate issues, albeit related. But if there's a way to do that, at least in the short term, I'm just very conscious that many older people have been deconditioned, are still very nervous about coming out, that their quality of life has very much reduced as a result of lockdown and knock-on impacts. And I think it's worthwhile the board having a separate item for that.
Thank you. Rachel, do you want to respond to that? Or
yeah, I think that's yeah, I think that's really good feedback. And we need to make sure that we are broadening our priorities, making sure that we're updating them, using our population health information, making sure that we're engaging with populations, particularly in living with COVID and recovery, and making sure that we are covering the broader group. So I think that's the point of having a starting point of priority, is how we expand them, how we build the narrative around them, and more importantly, the delivery plans and what we're actually going to do for older adults or particular groups. So yeah, I think that's really good feedback. Thank you.
Great. And Olivia, you've got your hand up.
Thank you, Councillor. I'm interested, maybe this is a sneaky peek, but what sort of ways of engaging are you looking at, bearing in mind Lena's comments earlier and the established routes and relationships that you have through your local health watch, your voluntary community sector, and all the rest of it. I'm conscious, of the resident survey that was done in RBKC last year that had like 600 responses, and I know there's enthusiasm to increase that. So I'd just be, if you were able at this point to give us an indication of what your thinking is.
Thanks, Olivia. I think that okay, Chair, shall I come back in? Yeah, I think we need to build a really good engagement plan. Obviously, talking to colleagues as I'm new in, lots of existing engagement mechanisms that are already there, plus some existing engagement that's already taken place, and making sure that we build that in and that we're utilising what we've already heard as well, and that we're not always asking the same questions of the same group. So rather than sort of list out, well, we think we should do this, I think it is going to be about involving all of us and involving the right people to get a really good engagement plan worked up so that we can build that in. I think that's probably the best thing at this stage. And there are already really good existing arrangements in place, is my understanding.
Could I come back on that? I think
Sure.
What's important is that we've shared a lot of people's experiences, particularly through COVID, and an appetite for action, to see a tangible change as a result of those conversations and the time that people have given in responding to surveys and participating and supporting and such like. So I think that alongside any engagement work, it would be really helpful to have some sort of commitment or parameters around what will affect change in this, what is possible and what isn't, so that we know that something's really going to happen as a result of that. Thank you.
Thank you. Yeah, absolutely agree.
Thanks. Now, Jenny, you've got your hand up next.
Yeah, hi. Not to repeat Olivia, but just for the sort of point of view of the voluntary and community sector, just to plead that if you do come to us to get opinions, which would be great, please do allow enough time for us to go and ask service users and get back to you, because obviously there's a sort of built-in delay there. And also the same point as Olivia, really please feedback to people and manage their expectations about what information they'll get back when and what the actions will be. Thanks.
Thank you. We will do that.
Thank you. And then Joe, your hand's up next.
Yeah, I was just more just to kind of add to sort of the discussions as well. I think, you know, when we talk about engagement, we talk about asking for information a lot. And Rachel, I'm not sure if you think as well, I think what we need to do is create the space for us to be involving our residents as well as part of the co-delivery, because this isn't just about us doing something to the residents, it's about the residents leading this as well. And I think a lot of this, you know, we're starting to hire local, you know, local residents to work on local things as well. This is about creating that space and time and doing that and how we pull that together. So I think this is the health and well-being strategy, and this work will be exciting because of that. But I think it's the collectiveness of this board that will help contribute to shaping that.
Thank you, Joe. And then Lena, you've got your hand up. Oh, but you're muted, sorry.
Yeah. I just want to thank Joe, because Joe said exactly what I wanted to say about engagement. It's not just about the usual process that the council and others use when it comes to engagement activities, coming to the community and asking them, what do you think of this? We want to do this. This is our strategy. What are your inputs? It's not that kind of engagement. Engagement is community engaging with the council and NHS, not the other way around always. So what I just want to echo what Joe just said. Please do define your engagement processes quite differently in terms of what community understands about engagement. And this is same with co-production and co-design and so on. It's all about community taking the lead, not the other way around. Very often the council sets the agenda and comes with that agenda and expects the community meet that agenda and be driven by the council. It should be the community driving the agenda. That will make a completely different, you'll end up getting far more productive, meaningful outcomes when you have such a process in place.
Thank you very much. Really good input.
Thank you. Yes, quite a lot there for Rachel to take on board, but obviously this is, you know, we look forward to seeing how that all comes into being. Do we have any other questions on this item? No. Okay. The next item is meant to be Rob Hurd. And thank you, Rachel. Sorry. Thank you very much. The next item is meant to be Rob Hurd, the new Chief Executive for the North West London ICS. I'm aware he was not available until just after 5. So given we're running just a minute ahead of time, I'm just going to move item 9 up the agenda, and that would be Anna Raleigh giving a quick update on the epidemiology and local vaccinations in the 2 boroughs. And then obviously if Rob joins us in a short time, we'll pass over to him. So over to you, Anna. Thank you.
Thank you very much, Councillor Kamali. You've got a few slides in front of you, which you can refer to as I'm talking. I'm just going to run us very quickly through the key headlines and talk a little bit about our key population groups. So the good news is that the case rates in our boroughs continue to steadily decrease alongside national and regional rates, which has been the pattern for the last 2 weeks. We are running today at a case rate of 754.2 per 100,000 in RBKC, and in Westminster we have a case rate of 685.9 per 100,000. Since the start of the pandemic, 310 RBK residents died with COVID-19 included on their death certificate, and in Westminster City Council, 448 residents died with COVID included on their death certificate. I'm going to bring us on to the next slide, which basically touches on the case rates across London. You can see this is Tuesday's data, but essentially you can see that the case rates in the northwest of the borough or in the northwest of London are some of the highest case rates in London. Hounslow, I believe, is there with the highest case rate. But overall, we are seeing that decline regionally, and we are seeing that decline within boroughs. In terms of our 60 plus population, which is on the next slide, you will see that we are also observing that decrease in the 60 plus population, and this is a pattern that we've seen over the last few weeks. Colleagues will know that as of January the 10th, there has been a change to the testing advice and guidance. So this impacts on the data that we're looking at in terms of the case rates. So since January the 10th, people do not need to undertake the confirmatory PCR, and they are asked to record their LFT tests. And we know the recording of LFT tests does tend to be low. For that reason, now when we're looking at this data, we're looking at it alongside the national surveys, particularly the ONS survey. And those surveys are showing, you know, we're triangulating them with our local data, and they are showing that the percentage of people testing positive for coronavirus has continued to decrease. In the weekend, in the 22nd of January, there's a bit of lag time on that data, and it's estimated that 1 in 20 people have had COVID. So happy to take any questions and queries, but at this stage we're moving forward with cautious optimism. As you know, we have moved from Plan B back into Plan A. That has meant that a number of changes have come in the last 2 weeks. The most important of these has been, of course, the return to work. Alongside that, face coverings no longer advised for staff and students. Since midnight last night, no longer mandatory to wear face coverings in most indoor settings. And from midnight last night also, venues and events no longer are required by law to check visitors' NHS and COVID passes. Some measures do remain in place, including those on self-isolation, and we are continuing to encourage people to get vaccinated, if they are vaccinated, to get boosted, to test regularly, and those messages around hands, face, space and air remain important. Thank you very much, colleagues. Happy to take any questions.
I think everyone is very familiar with these slides now, Anna, so I think you presented that very well. There's our last chance for any questions before we revert to the original order of the paper, order of the agenda. There we go then, Anna. Thank you very much for that one, and nice to see a screen with lots of green on it. We're returning now to item 8, and it's great to be able to be joined by Rob Hurd, the new Chief Executive for the North West London ICS. And really nice to meet you, Rob. We haven't met in person, and I'm sure many of us in this virtual room would be very keen to. But over to you for your verbal update on your new role. Thank you.
Thank you very much, and good afternoon, evening, everybody. I'm basically here to say hello, introduce myself as part of a programme of my induction, as I have joined at the beginning of this month the North West London Integrated Care System as the Chief Executive. A few words about who on earth am I. I've been an NHS leader for 30 years, and I've come from next door in North Central London, where I've been the joint ICS lead there. I am, as I say, on a programme of introducing myself, meeting people, getting my feet under the desk. Some early priorities for me, obviously, with the legislation coming in, with the formal creation of integrated care systems, currently estimated to be on the 1st of July. Where I'll be picking up the role as accountable officer for the CCG, as the clinical commissioning group of North West London, as Joe Olson retires. So early priority on the safe transition of that organisation into the new organisation. Clearly a big priority on the development of place and the borough partnerships and how we work together across local authorities, social care, health and care services, voluntary services locally. A big focus on the workforce challenges that we face within that, and workforce well-being, all within the guise of the ultimate objective of population health inequalities, improving quality of care. So I wasn't intending to go into much detail because I would hope to be back for more, and I'm sure you will be have lots of agenda items over what I hope are many months and years ahead as we go on this journey together. And I just wanted to say hello, welcome the opportunity to meet you all virtually, and put a stake in the ground of my intention to continue the journey of partnership that has already begun. It's a evolution, not a revolution, and I'm sure that we will have some interesting discussions ahead at Health and Wellbeing boards as we create integrated care systems, really support the success of place and borough partnership, and wrap around that the new NHS structures that are coming in with the legislation. So thank you for the opportunity to come along.
Thank you, Rob, and thank you for taking the time to come today. Does anybody have any questions? Councillor Mitchell, your camera's gone on, so perhaps you do.
Yes, hello, Rob. I'm Jem's opposite number in Westminster. I just wanted to give you the opportunity perhaps to share with our by-borough health and wellbeing boards your vision for how health and wellbeing boards will be integrated into the consultation and decision-making structure of the ICPs and ICS. In saying that, I'm very conscious that we are here on the divide between the local authority world with our own acronyms and all the challenges that presents for our community, and the NHS world, who also are inflicted with many acronyms. So apologies to Lena and other people for talking about ICPs and ICSs, but I think most of us on this call are now familiar with the new and emerging architecture, which of course is not quite in place yet.
Indeed, and I think your final point is important there, because some of this we're going to have to design together. Some of it is, what's signalled by the legislation. Some of it is very much work in progress on how exactly all the different component parts are going to sit together. However, the role of health and wellbeing boards will remain fundamental and need to flow into the structures of who we talk to, who we engage with, how we make an informed, high quality decision making that can only take place if we are properly having the processes of scrutiny and the processes of a partnership. So I don't have any prescription for that says that we're going to do this in a particularly different way in the immediate future, but we're going to have a mechanism by which health and wellbeing boards are going to have continued formal role in scrutiny and review and partnership of strategy decisions, big ticket items that are affecting resource allocations across the patch, service changes, reconfigurations, etc. And I know you don't know me very well, but I hope I have a track record of speaking early about things in earlier stages of involvement and engagement widely with plans and setting for the future, because the success and quality of how decisions are made and quality of implementation of things rests on the quality of the understanding of all aspects of change, improvement, and things that we're trying to do. So it's a really difficult question for me to answer in my first period coming in, because partly I have to get a feel for some of the dynamics at the moment before, and all I would say to you is it's about evolution, not revolution. There's not major change. The idea of this is to try and not make it a distraction, and it shouldn't matter what an ICS or an ICP is. It should matter what impact we are having and unblocking the things and working together on making the right decisions, and yes, paying due regard to appropriate scrutiny and input into all of the processes for decisions around changes, big resource decisions that we're making as an integrated care system. And I do apologise if that sounds a bit waffly, but this is on the basis of just coming new into a new system and treading very carefully with my words, so as I come in and continue the conversations that I'm having.
Thank you.
If you wanted to be more specific about any particular worries you had and you wanted me to take away, I would I welcome listening to them.
Councillor Mitchell, anything specific?
No, I'm sure there are many others on the call. I see Olivia has already put her hands up. Olivia's from our Health Watch, and so she's very close to many patients. And so I'm sure there'll be many others around this virtual table will have opinions But I take your point in that we're still in a position where we don't quite know what the final architecture is.
Yeah.
But what I would say is that Gem and I find the Health and Wellbeing Board an extremely valuable forum for consulting across our communities, and I urge you and your colleagues to embrace them.
Absolutely. Can I just totally support that? It's absolutely vital we get the involvement right. I don't use the word engagement, I use the word involvement. The how we actually make the decisions that we're required to make, or the plans that we make, absolutely have to have community insight, local insight, health watch, patient involvement, expert user involvement, and indeed on the board of the ICS we are very keen that we have that expertise in involvement, because ultimately that is what we're tasked with. If we're going to improve population health and improve the quality of how we do that, it's the fundamental engagement of the health watches, all forms of local engagement in those processes is vital.
Thank you, Rob. And yes, coming now to Olivia, who's had her hand up.
Hello, Rob. Lovely to welcome you to our beautiful boroughs. I have a little advantage. I deliver Health Watch in Enfield, so I can give some confidence to my colleagues that I've been very impressed with the approaches of North Central London, and I will big it up for Enfield because they've got under my skin, that borough. But I think we should be heartened and encouraged by the approach that NCL have taken, and I'm sure you must have had a hand in that, with the real insight and the real commitment to working with the local community and local community organisations. You know, I think it's going to be good, and I think we would like to encourage and see some of those approaches echoed potentially, but also acknowledging there's been significant funding coming into North Central London that we might not see in North West London. That has really made a difference. But also the digging in with the relationships built over a number of years, which you know, I can see with Deborah McBeal in Enfield. So I'm very excited that you're going to be arriving in our boroughs. Thank you.
Thank you, Olivia.
Lena, over to you. Still on mute, sorry.
My warm welcome to Rob as well. And as Olivia said, Rob, you will have such a great enlightenment if you come and visit us in the community. And Church Street is nothing like any other boroughs, any other wards. It's a unique ward, so culturally diverse, at the same time many health challenges. Olivia is laughing and smiling, and I know what she is saying. And you're all welcome, all of you are welcome to come to Church Street. We can facilitate a great meeting for that exposure visit. Quickly, I want to take this opportunity to talk about COVID, long COVID, which is becoming a huge issue right now. Since Christmas, our communities are becoming increasingly anxious about COVID-19, and the patients are not receiving any meaningful help, information, advice or guidance, and that is really causing a lot of mental illness. Suddenly this mental illness is different from the kind of mental illness they had before this long COVID. The symptoms are different, and the symptoms and signs that are continuing even after they've completed their isolation period, and they just do not know where to go. There are no real pathways that are being referred to them by their GPs or anybody else in the community or other service providers. So if this issue could be addressed, we had a meeting with Imperial College people this morning, and they are having a consultation meeting with us. We did a survey in the community, identified several problems related to long COVID. So I really want Northwest London CCG to take this up as an unmet need in the community.
Sure, I don't want to talk out of turning because I can't see everybody else on the call, so there might be more experts in long COVID pathways in Northwest London on this call than I am, as I'm more of an expert in North Central than Northwest. But I'm happy to sort of take that away and find out what's happening there and get some information back.
Thank you very much.
Thank you. And we've got Mona, your hands up.
Yeah, I was just going to say to Lena's response about the long COVID. So there is a long COVID pathway. In fact, it's by Imperial, and there have been actually training and awareness sessions that were set up, and so that primary care is aware of this. And we have, and it is available for patients to be referred to. And I know practices are doing that, but there had been some issues in terms of capacity, because clearly even the long COVID pathways were affected when we had the Omicron wave. So bearing that in mind, I think that is probably, it started and then all of this happened. So I think it will probably take off, but it's useful to get your feedback to know that we probably need to push that on a little bit. But there is a clear pathway. We're lucky to have Imperial within the patch, because it is a sort of, you know, it's probably a good example of how a long COVID pathway should look like, because it's well advanced in its workings.
Thank you very much. Thank you.
Thank you, Mona. I'm not seeing any other hands. Okay, well, I suppose it's really just then for me to say, obviously, Rob, you'll find we all think our boroughs are unique in Northwest London. Obviously, Westminster and Kensington and Chelsea are rather more joined at the hip through the by-borough arrangements. And, you know, we really do, whilst we recognise sort of the uniqueness of our individual boroughs, we do share a number of similar issues. And of course, we're really looking forward to sort of finding out how best Northwest London as an ICS is going to be able to tackle those issues. Obviously, Central London, you'll have good experience of that already. Is that much different from outer London, and we have many issues with international populations and such like that aren't quite the same as elsewhere. But really looking forward to sort of getting to know exactly how you see the plans shaping up. And if nobody else has anything to say, I suppose we can say thank you for giving us your time, Rob. That's really kind of you to come along today.
No, thank you, and to be continued. And thank you very much for this early opportunity to say hello.
Brilliant, thank you. And that moves us on to item 10, and we've been very efficient today. So thank you, everybody that's presented papers. We're on to any other business. Anybody have anything they wish to raise? The efficiency continues.